Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Updated Treatment for Hip Pain and Arthritis, presented by Dr. Bryant Bonner, orthopedic surgeon with Washington Hospital's Institute for Joint Restoration and Research. Dr. Bonner was born and raised in Sacramento before heading to Boston for college. He received his undergraduate degree from Harvard University and his medical degree from Harvard Medical School. Dr. Bonner completed his orthopedic surgery residency at the Harvard Combined Orthopedic Residency Program. And now, please welcome Dr. Bonner.
Good afternoon, everyone, and thank you for joining us today. My name is Bryant Bonner. I'm a hip and knee specialist here at SAW Orthopedic Associates at the Washington Hospital Institute for Joint Restoration. And today we're going to talk about navigating hip pain and specifically some insights on outpatient hip replacement. So you already heard a little bit about me, so I'm going to recap again. So I was born and raised not too far away from here in Sacramento. I went back east for what I thought was just going to be a 4-year stint of college. I ended up staying there for a little over 15 years. I got my undergraduate, my medical school, as well as completed my orthopedic surgical residency training, all at Harvard. I started making my way back west and completed a specialized fellowship in hip and knee replacement and complex and hip and knee revision surgery in Salt Lake City, and then I joined SAW Orthopedic Associates shortly after that. Some of the procedures that we do at our practice include total knee replacement, partial knee replacement, and what we're specifically going to highlight today, which is total hip replacement. We also have specialties in multimodal pain management, minimally invasive surgery, as well as rapid recovery techniques. We're going to specifically highlight outpatient joint replacement and the anterior hip replacement today. And I've given a previous talk on robotic assisted knee replacement as well. There's going to be a lot of information thrown at you today, and so if you ever want to do a deeper dive or do a recap, you can visit our website here. You can also give our office a call here, and then my email is also listed here, so if you have any questions, concerns, always feel free to email me. That's the best way to get a hold of me quickly and directly. So just a brief overview of what we're going to chat about today. We're going to chat about hip pain in general, what hip replacement surgery looks like, specifically the anterior hip replacement that we specialize in, what some of the new technology is that we incorporate into that operation and the surgery today, what surgery looks like here at the Institute of Joint Restoration, specifically highlighting outpatient joint replacement surgery, and then we're going to wrap it all up at the end. So just to start from the basics, we're going to chat about the anatomy of the hip. And so on the schematic here, we have our skeleton. Our hip joint is here down in the lower bottom. You can see the pelvis and our hip joint here. We're going to zoom in quickly. And you can see the anatomy here. It consists of a ball and socket joint. So the top of the femur or thigh bone forms this ball, and then the part of the pelvis forms the socket or acetabulum. Both of these ends are covered with cartilage, which glide very smoothly against each other. It's slippery than ice on ice when they work well and work in tandem. There's a lot of other muscles and tendons that are involved as well, but today we're just going to focus on the bony anatomy. So by far and away, the most common reason that patients have chronic hip pain is arthritis. And arthritis simply describes the loss of cartilage from the ends of bones that move against each other, or the joint surfaces. You can get it anywhere in your body, your hips, your elbows, your knees, and unfortunately at the moment there's no current way to regrow that cartilage, so once it's gone, it's gone. There's a number of different types. They include inflammatory arthritis. That includes things like rheumatoid arthritis, psoriatic arthritis, etc. You could have had trauma, so a fracture or an injury, which then can damage that cartilage that will break down and cause some arthritis in the future. But by far and away, the most common type of arthritis is what we refer to as osteoarthritis, so the general wear and tear as things go on. In the bottom left here, you can see a schematic. You can see the ball here, the socket over here. And normally this cartilage should be nice and white all the way throughout on both the ball and the socket side. In this schematic, you can see that cartilage is worn in certain spots, and you can imagine that the roughened cartilage is not going to glide very smoothly against each other. And that red represents all the inflammation and pain that folks are experiencing in the hip when that happens. On the top right, you can see some X-ray examples of it. So on the left-hand side, you can see a normal appearing hip with the ball here. The socket is this white line up above, and that arrow points to this black area in between, which is the joint space. So that represents your cartilage, your labrum, all of that good stuff. And you can see on the right, that joint space is now gone. That ball, that nice round ball, is now an abnormal shape. You see some bone spurs and the like. So some common symptoms of arthritis that patients experience consist of pain, stiffness, swelling. Patients may feel unstable or have developed a limp or changes in the way they walk as a result. And so the best way for us to diagnose this is in the office, and we start generally with a physical exam. And the patients come in all the time with hip pain all over the place, but by far and away the most common location of joint pain, the true ball and socket area, is in the groin. You can have pain on the side or on the buttocks, sometimes all the way in the medial thigh and down to the knee, but that ball and socket is in the groin. There's always that element to it. It's generally worse when you walk on it or you do any sort of activity. It's especially difficult to get up from a sitting position, and putting on shoes and socks can often be quite the challenge because that arthritis, the bone spurs, the loss of cartilage doesn't allow for a lot of motion, so patients tend to be stiff and limited. That's usually their first sign that there's some arthritis developing in that hip as well. In addition to the physical exam, we also get some X-rays at the time of the visit, and you can see on the left again, just to highlight, you see the nice normal looking hip, the ball here, the socket, this white line up above, and this black area in between, that's your joint space. So again, this looks perfect. On that right side again, just to highlight that ball is now misshapen. It's not a nice round shape as it once was. That joint space that used to exist between the ball and the socket is now gone. And you see down here some bone spurs and the like. So this is not a very happy looking hip. And once we've made the diagnosis of arthritis, how do we manage it? We always like to start with non-operative management that includes things such as medications, so Tylenol, anti-inflammatories, some over-the-counter topical creams that include things like Voltaren, Icy Hot, Biofreeze, Salonpas, etc. In addition, we can add some additional things like cortisone injections inside the joint or gel injections, which sometimes can help provide some relief. And then weight loss is, there's always a multiplying effect for every pound that you lose. It's 5 pounds less that your joint sees, so every pound counts. And all of these are help to try to manage symptoms. We're not treating the underlying arthritis, we're not stopping it, we're not reversing it. We're trying to manage those symptoms so that we can continue to do the things we need and want to do. But once these options are no longer providing that symptomatic relief or the ability to do what we need to do, we then start talking more seriously about surgical intervention. And generally it is a hip replacement, which is the most common and most definitive way, but some folks do ask about arthroscopy or a scope of the hip. Can we just go in and do a little bit of a cleanup, burr away those bone spurs? But arthroscopy has a really limited role in arthritis. And in fact, if you're trimming away some of that frayed cartilage or bone spurs, you can actually make that arthritis worse. And so, truly the most definitive and best treatment for hip arthritis is a total hip replacement. And so how does a hip replacement work? Basically, we remove the diseased joint surfaces and replace them with new implants. So on the socket side, we remove that, we clean out the damaged cartilage, we put in a new socket, plastic liner, remove that damaged ball and replace it with this pink one pictured here, and then a new stem that goes down the femur or thigh bone. All of this just to help recreate the normal joint mechanics of the hip. And you can see in that top right corner is an X-ray of what that looks like in a patient post-operatively. This is a very common procedure, and you can see in 2019, more than 400,000 people in the US received total hip replacements. So next, we're going to see a little visualization of what that replacement looks like. And so here's just a quick video.
Total hip replacement. This is a surgery
And
to
you can
fix
see
a
that
damaged or
damaged
diseased
ball
hip.
and socket.
The surgeon makes
which we're
one or
gonna
two
see
small
again here.
incisions to reach your hip joint.
So this is that
Then,
picture here
the
is
femur is separated from the socket.
damaged ball
The head
here
of
that
the
we're
femur
looking
is
at and the
removed.
frayed cartilage.
This surgery
that
replaces
socket
your
also
damaged
is not
hip
too
joint with
happy
implants
looking.
that
So
move
we
like the
remove
ball
that
and socket
ball
of a healthy
to
hip.
get access to the
Next,
cup.
they carefully
which we
remove
then
damaged
clean up.
cartilage and bone from
We
your
put
hip
in a
socket.
new socket,
They fit a metal
which
socket
goes
into
into
this
place,
cavity.
and a plastic
They also press
liner
a liner
provide
into
a
the socket.
smooth, near
The liner
frictionless
creates a
gliding
smooth
surface for
surface
the
that will let
ball
the
to
ball
glide
glide
on.
smoothly within it.
Next, we'll
Now,
clear some
we focus
room
on the femur
inside the
implant.
femur or
They
thigh
hollow
bone
out the end of your
to
femur.
then put in a stem.
Then, they place a
which
long,
you'll see
narrow
pictured
implant,
here.
which is called a stem, into this
It goes
bone.
into the
They
canal.
fit a ball on top of the stem.
There'll be
Finally,
the
they
ball
join the
that
ball in
fits
the
on
socket
top,
and test your joint
and
to
then
make
they
sure it's
click
working the way
together
it
like
should.
so.
Modern implants commonly have
All
a
of these
porous
implants
coating.
typically have some
This
sort
coating
of
will let
coating
your
on them
bone
to
grow
allow
into
bone
and
to
bond
grow
with
into
the
them,
implants as you heal,
to
locking them
further
securely in
stabilize them
place.
as you see here.
But in some cases,
Sometimes
your
we
implants
do use some cement and the like to help stabilize or reinforce weak or thin bone.
total hip replacement.
And so now we're going to pivot a little bit to specifically the anterior hip approach when it comes to hip replacement. Specifically, the anterior approach refers to just where the incision is made or the approach down to the hip. And so the incision tends to be made on the front, or we refer to as the anterior portion of the leg, rather than the back or the posterior aspect of the hip, which is the traditional way that hips have been done for a long time. It's nice because there's a natural plane that we can work through between muscles and tissues without detaching or damaging them. And then we also have the ability to use X-ray to confirm our component placement as well as your leg length at the time of surgery in the operating room. There's usually a specialized table that we use. You can see pictured down here that if you ever watch the YouTube video of Steve Carell talking about his anterior hip replacement, he refers to as a little bit of a torture device, but I promise you it's a well-utilized tool that works very well for us. So there's a million different ways to get down to the hip. So in this schematic, you're looking at a side view of somebody. This here on the left is the buttocks. Over here is your abdomen or the front of your body. You can see this blue dotted line refers to the posterior hip. You can see that's more on the back side. Where the anterior hip is this purple line here. It's more on the front. And so looking at a cross-body view, I think provides a nice demonstration of what we're working with here. So a patient is lying flat on their back. So back here is the patient's back. Up on the top of the screen is the patient's chest or abdomen, so that's the front. And you can see here is the ball and the socket over here. This purple line at the very top, you can see just goes straight down. This is that natural muscle plane that we exploit to get down to the hip. And so you see it's a nice, perfect, straight shot down to the hip for us to work through. So we don't have to damage any tissues, any muscles to get down to where we need to be. The standard posterior approach, unfortunately, there's just some muscles in the way that sometimes we have to get through or remove. We do reattach them or repair them, but it's not as clean cut as that anterior approach from the front. The anterior approach is not necessarily a new approach. It was first performed in the 1940s by Dr. Duget in France, and he actually had a specialized table which helped do these surgeries. But it was a little bit of a challenge, and there weren't that too many surgeons who were familiar with the approach, and it kind of fell by the wayside. In the early 2000s, this was revitalized by Dr. Joel Mata, who developed a special table and helped to reinvigorate this approach and teach it to different surgeons. And since then, we've only seen an explosion in the amount of total hip replacements that have been done from the front or anteriorly, and that's because of the added benefits that we'll talk about here that have really been a game changer in our field. So some of the theoretical advantages the anterior hip provides are that, as mentioned, it's a muscle-sparing approach, and as you saw on those previous slides, we kind of slip through these two different muscles to get down to where we need to work. As a result, patients tend to have less pain, and as a result, they're also able to get up and mobilize faster, so they can ditch their walkers, their canes, any sort of assistive device at a faster rate. In addition, we can use X-ray throughout, so we can really confirm the implant placement, as well as get your leg lengths dialed in. Because when you have arthritis, you have the ball and socket, and when you lose that cartilage, the ball tends to rise up and that leg gets short. We bring it back down when we put that hip replacement in, but one of the challenges is matching that other side. So the X-ray will really help us confirm that we're matching the other side, and we get you spot on perfect. The anterior approach also has a decreased risk of dislocation, so it's a more stable approach overall, especially compared to the posterior approach. So I'm sure you've had friends, family members, colleagues who've had a hip replacement in the past who may not have been able to cross their legs, bend over more than 90 degrees in the early part of the recovery. With an anterior hip, you can do all of that right away without the risk of dislocation. So since the advent of the resurgence of the anterior hip approach in the 2000s, we've only seen increased technology that has been coming into the forefront to help us do this surgery, safer, more efficiently, and more accurately over time. Over here on the left, we've always had the ability to template or plan our surgeries. We've usually done that on printouts with overlays, but they've since become more and more digital, where we can template, what size cup or socket we're going to put in, and the stem, and how that'll affect our different leg lengths. With the anterior approach, we're able to use C-arm, and that's this white machine here. So you can see the surgeon and one of the assistants here, and this X-ray coming into view here. And here's what that view from the machine looks like. You can see that we get an idea of where that cup is getting placed into the pelvis. So this is the pelvis here, and the cup is being inserted there. And this was great in that we were able to see and sort of mark onto the X-ray where the different angles and sizes, and make sure that it sort of act as a double check for what we were going to do. But it was still kind of rudimentary. We had to draw on the actual the X-rays. There was sort of a limit to the amount of lines and measurements that we could do. And sometimes we even had to do printouts and overlays to the other side to get the information that we needed. But there have been a really game-changing changes in technology, and especially one that we're using here in the operating room at Washington that is artificial intelligence powered. It allows for these patient-specific functional guidance throughout the surgery with these overlays and real-time image interpretation. And so you can see an example of this here on the right. It may be hard to see, sorry the contrast didn't quite come through, but the ball is here and the socket there. You can see your pelvis here. This software integrates with our existing X-rays. So once we take the X-ray, it can automatically detect the bony landmarks on both the femur or thigh bone and the pelvis to help give us some quick measurements and assessments, compared to the other hip on the other side, which exists. Here you can see the leg length, they're about 6 millimeters short. And so we can get an idea of where we're starting and where we need to go. And this also comes into play when we're putting in our implants themselves. And you can see, similar to what that view I showed earlier, you can see the cup going in again. But right off the bat, you can see some lines where the software will automatically detect those bony landmarks and then give us some information right off the bat. So where the implant is being placed, the inclination, the version, all of that to act as a double check and a verification that we are where we think we are, and make sure we optimize that placement at the end of the day. And more X-rays and integration here, where you can see where we're trialing different components to make sure we get the right size and the right fit, so that we've improved some of that leg length, but we're not quite there, so that we can make sure again that we're spot on, and comparing to the other side, those leg lengths are right on target. And so now we're going to chat a little bit about what the surgery looks like here at Washington Hospital, and what's a little bit different about what we do. And all of our patients get a link to a pre-op class. This has traditionally been in person, but now we've pivoted to more of an online course. It's been spearheaded by our PT, OT, and nursing faculty. And so most of our patients watch this video and have a printout to follow along with. And they help to teach you what to expect before and after the surgery. In addition, all of our patients get a pre-op binder for both our hip and knee replacements. That is your comprehensive guide throughout the recovery process. So again, it tells you what to expect before, after, some exercises to do, landmarks we expect to hit, and is really a key guide that folks should bring with them to their post-op visits and physical therapy as well. In addition, here at IJR, the Institute for Joint Restoration, we have tailored staff, including fellowship-trained surgeons, anesthesiologists, our OR staff, nurses, physical therapy, all of which are dedicated to joint replacement. This is all that we do. Our colleagues joke that we do 4 surgeries: left hip, left knee, right knee, but we get very good at those 4 surgeries. This is our bread and butter. And I think because of that, even though we're this small town in Northern California, our reputation and outcomes really draw a large catchment area with patients coming from all over Northern California to the Institute for Joint Restoration because of that. And it's not only what we think and what we see. We've been recognized for this nationally. We've been acknowledged as one of America's best hospitals, especially for joint replacement. 11 years in a row, we've been awarded the Healthgrades Joint Replacement Excellent Award, which means we're in the top 5% of the nation for joint replacement. 14 years in a row for the 5-star designation for total hip replacement, and 12 years in a row, the 5-star designation for total knee replacement. In addition, you can see on that right side, we have been awarded in the 50 best for outpatient joint replacement, which we're going to talk about here, specifically at Washington. And so outpatient joint replacement is an evolving topic and something that we've seen more and more frequency across the nation. And it's just been a trend even before the pandemic, but the pandemic certainly accelerated this at an alarming rate, and now more and more of our surgeries are being performed at an outpatient basis. Patients are recovering very well and very quickly, and so we're able to mobilize them, their pain is well controlled, and get them home safely. Certainly there's a cost element to it where there's decreased cost to both the hospital and the patient, but that's certainly not our main driver, and I think sometimes there's a misconception that patients might be sort of forced out because of that, but that's certainly not the case. Outpatient joint replacement generally consists of 2 different flavors. You can either have a surgery performed in a hospital setting, such as our main hospital here at Washington Hospital, and get sent home the same day. The nice part about this is it allows for the option of an overnight stay if we need it. The other option is potentially surgery at an ambulatory surgery center, such as our Washington Outpatient Surgery Center across the street. It's a little bit more relaxed over there with a little bit less administration, but there's not necessarily the option for an overnight stay. In general, outpatient surgery tends to be beneficial for patients, and talking to those who have gone home the same day, there is a certain element of increased healing that they seem to appreciate. I think that it's just less stressful than having to be in the hospital for multiple days. Traditionally, when I started residency, the typical hospital stay for a joint replacement patient was 3 to 4 days. As I've gone on further and further in my training, and now as an attending, you can see that stay has shortened significantly. And I think recovering at home just provides a more comfortable healing environment. You're in your own bed, you have your own food, you have family or friends available, a little bit more control of your medications. And I think, sleep is a huge part of the recovery. And so you're not necessarily getting bothered by the beeping and the noises from the hospital or getting woken up multiple times for vital checks and the like. So it can be quite a game changer. Looking at these studies, this is a major study done at one of our major journals. You can see the trends have only been increasing since really 2015. This doesn't even include post-pandemic, but you can see that this straight black line is total hip replacements that go home the same day or an outpatient. And you can see that sharp uptick in 2015, and it's only continued to rise at an exponential rate since 2020. And I think one of the major things that maybe gives some patients pause is there an increased risk of complications? Is it safe? And this paper looked at that, and looking at all comers, the complication rate is actually quite similar, whether you go home the same day or the next day after a total hip. So on the left hand, you can see this is the patients that go home the same day of surgery after a total hip. On the right side, these are the patients that stay longer in the hospital. And they looked at a number of different factors, whether it be heart attack, a blood clot in the lungs called a pulmonary embolism, pneumonia, sepsis, wound issues, and infection. And if you look at these numbers between the two, they are all quite similar. There's not a big difference between them at all. And part of that reason is we need to make sure that this process is safe for our patients. And so these are some of the check marks or hallmarks that we want to make sure that patients are hitting before they go home. And they all have to be working in tandem to get you home, or they don't work at all. The most important thing is we need to make sure that you're mobilizing well and that you're not a fall risk. Patients need to be safe. In addition, we need to make sure your pain is in a reasonable spot. It's not under control with our over-the-counter medications. You're not requiring a lot of IV narcotics or anything that is out of proportion or out of control. In addition, we need to make sure that your nausea, vomiting are well controlled and you don't have any issues urinating on your own. We also need to make sure that you are medically stable, so if you have any existing issues such as high blood pressure or diabetes, those are well controlled and in a good spot before you go home. And I think most importantly, we need to make sure that you have a coach or support system available at home to help you once you do get there. So there are a number of different puzzle pieces that need to fall into place to make this all happen and make sure that you're hitting those goals so that we can get you home safe. They include patient selection, the anesthesia that we give, the type of surgery, including the technique that we do, what we give you for pain control, and then again, that support system over and over again is going to be very, very important for folks. And so patient selection is very important that we talk to patients. We want to make sure that they're healthy, or that if you do have some health issues that they're well controlled, they're not very severe or systemic, that might require a bit more observation or time in the hospital to make sure that they're stable. I think sometimes we see some patients who are think that because they're a certain age, they are not able or qualified to go home the same day. But when studies looked at this, age alone by itself is not a contraindication for going home. There are certainly patients over the age of 80 that can go home safely, that are relatively healthy or have these mild issues that are under control. So that alone is not a contraindication to potentially being an outpatient joint replacement. In addition, the type of anesthesia that we give you makes a big difference. The less anesthesia that we give you, the faster you're able to mobilize, the better your pain is, and the less nausea and vomiting that you have. So for us, a spinal anesthetic plus or minus some sedation tends to be the best combination. Those folks who get general anesthetic tend to may need to stay a little bit longer just to recover. And then we also give a preoperative cocktail of oral medications in the pre-op area to help reduce both patients' pain as well as the postoperative nausea and vomiting that can slow down patients getting home. In addition, the surgical technique that we use is very important. So obviously we want to be less invasive, so the smaller the incision, the less disruption to you that we're going to do. For our anterior hips, the incision is 4 inches every time, 4 inches. And as mentioned, that approach tends to be muscle sparing, so patients tend to have less pain, they're more mobile faster, which we're hitting 2 of those check marks to get you home safely. In addition, we have medications that we give you in the operating room to help reduce blood loss. In addition, we use some devices to help stabilize any blood loss or coagulate anything that might be bleeding as well. In addition, the shorter amount of time that you're in the operating room, the better. And so, all of us are fellowship trained here at IJR, so that this is what we do time and time again. So that's why we can make that OR time as short as possible. In addition, pain control plays a big role, and so we specialize in multimodal pain control to hit it at different levels so that we can get you comfortable and mobilized safely. That includes a combination of medications, some injections at the time of surgery, and things that we plate inside the joint. And so I'll show you on this next slide all the different pathways that we're hitting from the brain down to the local site of the incision. And so you can see there are a number of different things that are targeting different levels of where that pain might be coming from. So from a top down, we're using medications like the narcotics or opioids, Tylenol, some anti-inflammatories. At the spinal level, we're using that local anesthetic, the spinal. And then they also can sometimes give some local pain medication there as well. Lower down, we'll give some anesthetics at the time of surgery inside the joint, and then at the side of the incision, we can also do some local numbing medication as well as the anti-inflammatories and pain medication. We'll hit it from there as well. And then finally, your support system is key. So as mentioned, making sure that you have a coach, a family member, friends, or et cetera, that might be able to help you with anything around the house that you might need to recover after surgery. That include things like meal prep, medications, just checking in to make sure things are okay, and helping to motivate you along your recovery process. And so just to conclude here, as mentioned, hip arthritis is the most common cause of chronic hip pain in all comers. We can always manage this non-operatively, but the most definitive and best treatment for hip arthritis is a hip replacement. I think some big advances in joint replacement surgery, including surgical technique such as the anterior hip, the anesthesia that we give, such as a spinal, and the pain control that we use to target multiple levels, as well as the technology that we can incorporate at the time of the operation to confirm both leg length and the component positioning, have really helped to improve postoperative outcomes and speed recovery. And so all of these things combine and together allow most of our patients to go home just a couple hours after surgery and to do it safely. Thank you.
Thank you, Dr. Bonner. We do have some questions for you today. The first question is, how do you determine if someone needs a joint replacement inpatient or outpatient?
So as mentioned, we chat with our patients. So patient selection is key, and that often comes from our side or the surgeon side. We want to make sure that patients are relatively healthy, or if they do have any sort of medical conditions, that they're well controlled and mild and don't require a prolonged observation. And then second, we make sure that they have a support system at home to be able to allow them to recover at home with a little bit of extra care and monitoring. And more often than not, that is the case. And so then it comes down to patient preference. And so most folks, if they have the option, prefer to recover at home if they're able to.
Okay. The next question we have is about inpatient and outpatient. What is the percentage of joint replacements that are done in an outpatient setting?
Yeah. And so looking at our data, I just looked at it today from 2022 to 2023, between Dr. San and myself, around 84% of all of our joint replacement patients were done on an outpatient basis. And then if we dialed into that data a little bit further, looking at hips alone, more than 96% of our patients after a total hip replacement were outpatient surgeries.
Okay, another question we have is, if I need to bring a support system in because I live alone, how long would I need that support system to stay with me?
So everyone's a little bit different, but we usually, for the first couple days, we suggest having somebody around or available. They don't necessarily have to stay with you, but at least be within close distance in case you do need an extra hand around the house. The good news is after a hip replacement, our patients tend to be fairly mobile, and in fact, we're actually trying to slow them down in many instances, but it's always good to have a little extra backup nearby or close in the house.
Okay, and our last question is, if I have hip pain and I want it assessed, can I make an appointment directly with you, or do I need to consult my primary care physician?
Absolutely. So you can call our office or visit our website here, and you can schedule an appointment with us directly. We're happy to see you anytime and check out your hip or knee and let you know what we can do.
Okay, thank you. That was a wonderful presentation. It's a well-oiled machine to have a joint replacement with your office. Obviously, everything's in place, and we've very much enjoyed the presentation today. We appreciate you, Dr. Bonner, for taking the time to be here with us today, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.